And you had a little bit of a lead in there. We'll get back around to let's talk about the hemostatic agents, right? So I mean, I remember early in my career, it was, oh my God, those things are actually going to burn the patient. And I remember that there were some medical directors in the early release that were very hesitant to let it out into civilian EMS. Where are we at now?
So Pharmacy Ray?
Yeah.
Pharmacy Ray.
So it's actually
P-Ray.
Yeah, exactly. He's like our pharmacy go-to, man. Go ahead.
So that's where we were in the past. A lot of the agents did have a thermal byproduct, if you will, or they created heat when we were using those, yeah. And that really shied a lot of people away from them. Now, after the exothermic reaction, I would say we moved more towards a granulate product as well, and it kind of coincided with that exothermic reaction. And now we went away from granulate as well. So if anybody's seen the movie Shooter, where Mark Wahlberg gets shot, he hops in the back of the police car and he rips it open and he's pouring in there. We don't like that agent either. Why? Because surgeons hate it. They have to try to debride that wound in surgery.
And wash it out. Get it all out of there.
Oh, yeah. And it just leads to infection. That's exactly where Dr. Dayer's headed. It's a huge problem. So where we are current date is, quick clot is they impregnate the dressings with colin is what the product is called. And it is to, increase clotting factors, help sustain those clots, help them to hold up, and it does not create heat anymore. So safe to use, definitely endorsed by, NAEMT. We teach it in TECC. Our medical directors are fully behind these products now. And, they are in Z-fold gauze, ABD pads, huge trauma pads. I mean, there's a large variation of products you can buy with them in there, and they're not going to create heat anymore. So very safe.
Yeah.
My other tidbit on wound packing is one of my pet peeves that I teach is, if I have a package of quick clot and I have a package of just regular rolled gauze, like Dr. Dayer said, I want to get that quick clot agent in there, right? So I'm probably going to start with that. And I think a lot of times as EMS providers, we're going to underestimate how large that hole or that void space we're trying to fill. So, what happens when I'm packing with quick clot and I come to the end of my little rope here and now I'm out? What do I do? So that's where I would grab my second roll of quick clot if I had it, or another roll of cling. I want to tie those together. And then I continue to pack that wound, right? It's one continuous long strand, right? I don't want to just push one in and then start with section 2. No, I want to make one big long rope. So I want providers to, keep that in mind. After the wound is packed, then we're going to do direct pressure on top of it. You got to hold it for about 3 minutes is what we teach in TECC. And then you can move to like that ACE bandage or the pressure wrap after that.
Israeli, I don't think we have an Israeli bandage.
No, I didn't see any. I was looking on there.
I got one in my kit out of my truck. I should have brought it in.
It's a blood stopper one. Kind of gives you the similarities to it.
Yes, I mean, just for in general.
Just conceptual.
Yeah, so and I pulled it up in here so you can see it, Scott, that this is what we teach. We actually reached out to this company called Dark Angel, and we kind of go over tourniquet the limbs and pack the junctions and seal the box. And, just to hit home, I know a lot of people are skeptical about packing where the neck is. It's just make sure that it's not going to be an airway compromisation. That's the number one thing. There's a lot of pros and cons of it. If it's not bleeding extremely bad and it's can use direct pressure, by all means do it. But if you need to pack the wound in there because it's hitting the arteries by your clavicle, then you're gonna have to do what you got to do. But just make sure you're not packing where your trachea is meeting, or wrapping Israeli bandage around the neck to kind of choke them out. So that's what that's
tourniquets on the neck.
That's what we use to teach. A lot of people are very hesitant about the wound packing up that area, but there's pros and cons to it, and it kind of is not a one size fits all. It depends on where the wound is. So
size of the wound, track.
Yeah,
there's a lot of variables here. Yep.
So that's just a little thing that we we actually have that we give out to the police officers.
Oh, you give those out?
Yeah.
Oh, that's fantastic.
It's like it's actually like a decal.
A little sticker, yeah.
A trauma guy.
Yeah.
Tourniquet the limbs, pack the junction, seal the box.
Yep. Awesome company. I reached out to them, and they're all about us using that little thing.
That looks like a Velcro patch.
Yeah, we got them for decals, and for all law enforcement that do our classes, we're handing them out. So yeah, patches are a little bit more expensive, but the decals.
That'd be good. You could just rip it off. Like, what do I do?
Yeah, we could swing the decals. I can swing the decals. So yeah, but that little image helps hit home a lot of what we're teaching.
So we early on we talked about in the hot and the warm zone, we're not doing advanced airways. It seems like the trend is more towards NPAs, nasopharyngeal airways, rather than OPAs. Pros, cons? What, if a department or an individual was putting a kit together, which direction and why?
I like MPAs. The whole thing way back when I was in medical school and going into the brain, it's not really feasible. I mean, there could be, but it's the studies have shown that it's not happening.
Probable.
Yeah, it's not probable, and it's directly making a line of a spot for the air for another airway. OPAs, you got facial injuries, you got the tongue, you got loose teeth. Sometimes they're just sliding out. Yeah, gag. They're not like they're usually they're moving around and it's not really in there. And MPAs, you just slide it right in and it works. I like that. And a lot of the RTF kits, they don't even. I mean, I've never seen an RTF kit have OPAs. It's all NPA.
No, I agree. 100%.
And I think that's a standard of what everyone's going with.
I would also imagine that it also opens up your patient population, so you got the semi-conscious patients.
Yeah, I mean, you can throw it
Now
into
it's,
one of us right now if we needed to. And that's what we kind of hit home of, is you don't want to keep a set of gear that, there's so many different styles of OPAs that it might not work for your patient. And why keep all that area, in your kit
That real
for
estate.
something that's
Sure.
not going to, it might not even work. So MPAs are very, they work well, and that's what a lot of the committees, and it's the MPA is good to go.
Mm-hmm. Take up less space.
Oh yeah,
Carry well.
Throw a ton of them,
flexible.
yeah.
Sure. So, any other essentially tools of the trade that we need to be talking about for the on-scene treatment of these patients? I think we hit a lot of these.
Junctional tourniquets.
Excellent.
Like the SAM junctional
Excellent
tourniquet
point.
or the JET, or
Croc.
If you have an
not the Croc.
so if you have an unlimited budget,
Yeah, if you have
unlimited budget, let's
Yes.
talk about junctional tourniquets.
Junctional tourniquets, I think, that's just for those areas that, so essentially I want to talk about the SAM junctional tourniquet. Joe can elaborate from whatever I miss. I'm pro that one compared to the JET. I think the JET's good, but it gives you a high profile. So you have the two pole arms that are going to stick out above your patient's waist or pelvic region that are going to be very tall. They're going to catch on things, harder to move them.
And just to step back for 1 second, just so people understand what we're talking about in case they're not
sorry.
familiar with EMS, junctional tourniquets are specifically made for the junctions that Joe was talking about. So the groin and axilla that you can't put a tourniquet on, that maybe you would pack, but another option would be to use a junctional tourniquet, which is a way that you can put pressure on those areas to help stop bleeding.
Yeah,
So-
and then it's just,
so
sorry,
people
thank you,
understand what
Dr.
we're
Day.
talking
I jumped way ahead. I got excited. No, it's a great tool for those places. Like Dr. Dare said, for the junction, it essentially works like a little BP cuff for the SAM. I'll speak specifically to that. You can clip on, pump it up, pneumatic pressure is going to push down. SAM actually has a little plastic clip plate you can put on top of the bladder, if you will, to apply more direct pressure to maybe the wound that you just packed. The other versatility of a lot of these products are going to be too, it's also a pelvic binder, right? So if we had any type of pelvic fracture, unstable pelvis on our assessment, we want to try to close that up because we know the massive amount of blood volume we could lose into that space. We want to try to prevent it. Some of them, it's what you like.
Yeah.
Joe, you can pick up where I left off.
Yeah,
Some function well.
So
some
there's
are
three
clunky.
main ones out there, and I'll have to name it because there's one called the Croc, and there's like 9 pieces to it, and you got to put it all together, and by the time you can put it together, the guy's dead. Yeah. So,
It's
but
like
but
a
it's in the
C-arm,
military.
if
So
you
I
can
mean, it
imagine
could,
what a C-arm is like.
Yeah.
It's basically like a C-arm.
Yeah, I mean, it could work in the military pre-hospital setting already set up, but I wouldn't be wanting to put this together in a cold zone when there's 9 different pieces to put together. Don't like that. Jet works well. I call them. They have it's like pizza slices. They're like the little nylon that you put onto the wounds, and they have like big T-arms that you crank down. For our team and for university hospitals, we like the SAM. Jet works great, works good. The SAM and Jet do pelvic binder. The
Blush.
Excuse me.
the SAM pelvic binder can go into the groin, but also you can use it up in the armpit area too. Downside about the SAM is it does use pneumatic air, so if that bladder punctures, you're SOL. That's the only downfall. But I like it how it's more low profile. The Jet has the big T arms that come up, so Metro and Tag they use the SAMs, and I haven't had any issues. We haven't really used a lot of them. But it's more versatility. I like how it's a pelvic binder, how you can go up into the axillaries, and you can do low profile stuff. That's what I like about it, and it seems like a big consensus they're going that way. There's another one out there. It's not junctional, but it is a pelvic binder by Crow Medical, but they don't. It doesn't do the junctional
Occlusion.
the occlusion, no. But it's more of like a pelvic binder, and it uses the BOA system, like you see like on the back of like a tactical helmet or boots. A lot of places are using it, but it works really well. But it's just missing that feature. So,
All right.
what are you smiling at?
What's up?
Because I'm ready to just throw the grenade on the table here. TXA, go.
Trans-ischemic acid, right? TXA. So why do we use TXA? For somebody that's going to show signs and symptoms of shock, right? So we have tachycardia. Maybe you have a low systolic blood pressure, a low mean arterial pressure, and we are going to be able to administer this drug. I think one of the huge misconceptions with TXA, right now we currently use it as a drip, right? So we take 1 gram of TXA, we'll draw the whole gram up, and we will inject it into a 100 ml bag of D5. You can then invert the bag, because pharmacy doesn't like the word shake.
I shake the bag pharmacy, I'm sorry.
We'll never get our stuff done ever again now.
That's it.
Ray told me not to, but I didn't.
No, I can't say shake, but we'll invert
We'll
it
invert it.
and gently, aka shake it back and forth really fast. And you can then spike that 100 ml bag of D5 you've added 1 gram of TXA to, and we'll use a 10-drop drip set, and we're going to deliver that over 10 minutes. So that's about 100 drops a minute if you do the math. It's difficult to do that in that setting, so I always try to tell people look for 25 drops in 15 seconds. That kind of gets you going. We do have some windows and some capabilities with TXA. We want to give it within the first hour of the onset of injury. Once you get outside of that window, in our protocol currently, we won't administer it anymore then. If you read the studies on it, I want to say it was the CRASH 2 study that talked a lot about bleeding, a lot about the use of TXA. This came from the military, a lot of it did. If you get out towards that 3-hour window, we actually
The military was actually the Matters trial.
Oh,
It was
the Matters
second one.
trial.
Crash
That's the
was the European. The first trial was the European trial.
Classic Ray, man.
apologies. My bad.
Is there like
That-
was there like a
that
horn on
became
here, like a
matters.
clown horn? Is there a clown horn on this thing?
We gotta edit that out.
That'll be edited out.
Yeah, can you edit that? Can you edit that?
My bad. It was the Matters when I screwed it up.
Yeah.
It's not like we've been standing here talking for hours or anything. you know?
No, I know. Sorry. So either way, when we get out to TXA and its limitations, it does need to be administered within the first hour. If you get out towards like the 3-hour mark, it actually increases our mortality rate if you read some of the studies. But given it's easy, I think one of the biggest false impressions of this drug is it's just magically going to drip clots down the drip set, right? I'm going to spike this, and it's just magically going to send clots into there. It makes clots, and it does not. Right? What it does is it is essentially the easiest way that I explain it in any class that I teach is when you cut yourself and you're bleeding, your body's reaction to that is to try to stop that. Right? You're going to get that buildup of fibrin and plasma. You're going to try to stop your bleeding. It's going to try to fix itself. All TXA does is it makes your clots less likely to break down. Right? It's trying to make your clots. It's trying to slow it down, and it's trying to essentially strengthen your clots. Would be my example of how TXA works on a very simplistic level. It's just trying to give them more sturdiness, if you will, so they're less likely to break down, right? We always perform our basic bleeding control measures first, right? So we're going to do direct pressure, we do a tourniquet, but TXA could still definitely be administered in the background to try to help that patient. Contraindications for TXA would be a patient you think that's having a PE, right? Not a clot we want to make stronger, an MI, or a stroke. Those are pretty much the 3 contraindications for TXA.
Traumatic injuries.
Yeah.
Who's TXA not going to work on?
Um,
Because everybody just makes clots, right? I mean, everybody clots exactly the same way.
yeah, right. They not like hemophiliacs. They don't clot the same as the rest of us. But the other thing about TXA that just to mention is that there is talk and there are protocols out to do TXA as a push dose now. So we probably will be getting away from having to run it as a drip, which will make it easier to administer as well.
Because the military, they just drip this all the time, right?
Exactly.
They probably have been for 3 years. Now we're finally getting it. Yeah,
they've been hand pushing it for a fair amount of time.
Yeah,
and the other point to be made is that's now 2 grams.
Right.
It's 2 grams push.
It used to be a gram infusion initially, and then a second 1 gram infusion in the hospital. And now they've simplified it to say, hey, give all 2 grams as a push right at the beginning, and just be done with it.
And as of the time of this recording, that is in discussion to be an EMS protocol, but it has not been finalized. So so check your protocol.
Yeah.
We may or may not be there based on about how things progress, but that seems to be the way most things are going. So
Sure.
It's just easier. It's just easier, faster, get the med in the patient quicker.
Yep.
So I think that's where we're headed for sure.
All right. The other thing that I've got for you, Dr. Dare, is CPR and traumatic injuries. It's
Yes, absolutely. We can save everybody.
you can save absolutely everybody,
There's
right?
no reason not to try to save people.
I think some conventional teaching was the blunt versus traumatic, and obviously the blunt, if you try attempt resuscitation on scene and it fails,
Right.
they're dead. Right. Does CPR need to be part of that? Again, this is just general clinical medicine, but I know there's a lot of people that stumble on this. I just want to bring it up.
Sure.
In that resuscitation of the blunt, the on-scene resuscitation of the blunt traumatic injury, is it appropriate to do CPR, or are we just going to focus on the things that are reversible, i.e., tension pneumothorax, bleeding control?
So it depends. Some of it depends on what resources you have, right? I mean, if you have all the resources in the world and it's a young, healthy person and you're going to try, okay. The reality, though, is that there was a big study printed in the American Journal of Trauma or whatever it's called, and they did CPR on I think 196 trauma patients, and absolutely 0 survived. Right? I mean, the survivability from a traumatic arrest in a blunt trauma patient is essentially 0. So for the most part, yes, they're quick reversible things, right? Tension pneumothorax. Can you open an airway? If you try those things and you get something, great. But more than that, I wouldn't put a lot of effort into it.
All right, same question. Penetrating trauma.
So penetrating trauma, if you can stop the bleeding and fill the tank back up, you may have a chance of survival. So it's not 0, but it's still pretty low. But there's more chance of saving penetrating trauma because you can clamp a bleeding artery and pour blood into people and potentially get them back.
So if we've plugged every hole the best we can, we are transporting, because we do transport penetrating trauma just for that. It's a surgical case. Hopefully we can clamp them off and save them.
Sure.
But they have no appreciable pulses. That's somebody we would spend some time doing some compressions on.
I would.
Potentially salvageable.
Sure.
Yeah. So fantastic. That's. I think.
We smoked that list.
I think we have basically killed this list, right?
Yeah.
Anybody else have anything that
We didn't talk
Fluid.
about that.
we don't need to?
Fluid
We talked about
resuscitation.
that.
Yeah.
Oh, fluid resuscitation.
Just don't want to cause fluid washout. Don't want to flood them, coagulopathy. I mean, I would hope our providers know that enough.
Yeah, I mean, we just real quick, the thought used
Pasta
to be,
water,
hey,
yeah. Don't be giving them pasta water the whole time to wash
everybody,
it out.
we used to get 2 liters of fluid for all their trauma, no matter what was wrong with them. And we realized that we were just diluting out clotting factors and reopening blood vessels that had constricted to stop the bleeding. And those are both bad things to happen. And if you throw cold IV fluids into causing hypothermia, that's also another bad thing. So we don't want to over-fluid resuscitate people. We are comfortable with permissive hypotension and systolic blood pressure just to 90 or above. And we don't need to give a ton of fluid to trauma patients.
Yep.
I think that's fluid resuscitation in a nutshell.
That's it in a nutshell, right?
Yeah.
But it's you practice like you were trained. I got to admit, sometimes it's I got to throttle myself, because I tell a story. Long ago, I remember we were on MBA, and it was what was the old mantra? Replace 3 liters for every liter lost, or something like that. It was something bonkers, 25 years ago. She got like 8 liters of saline before we got her out of the car, and thinking back in that retrospectively, it's like, yeah, the surgeon had an amazing time with the Kool-Aid mess that we made him, right?
Right.
I feel bad for that guy today, right? So.
Well, the mantra now is replace what you lost, right? So the military is using whole blood. And
absolutely.
That may be coming to civilian EMS. I mean, there are some places across the country that have some pre-hospital transfusion protocols
air
in
meds,
place.
stuff like that. Yeah.
Well, I mean, the helicopter services do or whatever, but I think I remember Houston maybe or
It
somewhere
was Houston
down
and Gems.
there.
Yeah, there was an article in
I
Gems
think-
about them carrying whole blood.
Yeah, I think they I think have like a blood car that will respond to scenes that potentially would need blood, kind of like a chase vehicle sort of concept. I think is what my understanding of that is. So the military uses whole blood. And now in the hospital, we have to sort of remix the blood, right? You donate blood to somebody, or the Red Cross or whatever, they split it up into platelets and plasma and red blood cells. Now we got to put all those components back together in the hospital if you have a trauma, because we want to give you that whole blood again, but the military just keeps it as whole blood and uses that for transfusions. So that may be coming to EMS at some point in the near future.
Just got to get all the donors to show up.
Right.
Yeah.
We just need a product.
And retrofitting all the squads that don't have all the refrigeration and
Sure.
some of the
I
atoms.
think that concept of you're going to have a zone car.
Oh yeah, for
chase
sure.
vehicle or
Yeah.
something.
Everybody's not going to have it. But it's going to be a regionally available asset. If you will.
Oh, for sure. Yeah.
Just such a limited supply, limited donors anymore.
Oh,
it seems,
Just the management of it alone
Yeah.
is a nightmare. All right. Closing thoughts.
I just want to say to you guys, thank you for having us come out and talk to you guys and the people that are listening about what we're doing for University Hospitals. And our goal is to make sure that anyone that's under University Hospitals' affiliation gets taken care of with training and medical supplies. And that's what we're here for. I mean, that's what we were approached for, and I think we're doing a great job, and we're just trying to get the word out that, this is for, UH people, but if everyone else wants to join, we have room.
Yeah.
We'll do some fun stuff together. I just, we just want to make sure that we take care of the UH family, and that's what we're here for. And that's, I'm very excited to get this rolling. I mean, 7 months, I think we've done a lot. And I mean, we started with, me, Mike, and I remember having a phone call with Ray Pace and Dr. Dare. Dr. Dare was with, when we first did the classes, but, we started with 2 guys and getting Ray on, to now we have about 15 instructors that are doing a whole lot of other stuff for Northeast Ohio, and we got a lot of exciting things coming in 2023.
That's awesome.
Don't want to talk about it yet, but it's going to be.
We're expanding
It's going to be a game changer in this area. I'm telling you right now.
Sweet.
Yeah.
Right.
But maybe you'll invite us back and we'll talk about it.
Part 2.
Yeah.
Part 2.
Yeah. And I didn't swear. Aren't you happy? I didn't.
I think I only swore once.
Yeah.
But
Joe Sugar follow up too.
Yeah.
Just make sure you
I
differentiate.
want to leave that cliffhanger. No, I'm just kidding.
All right.
They probably turned this off already. So.
As long as you differentiate him and his father in your phone,
Yeah.
because they're spelled the same. I had a very nice conveation with Joe's dad
his
one
dad.
Yeah, with my dad.
for a while, and then he's
And
like,
my dad goes, "Yeah, I think you're trying to get a hold of my son," and then he called me. So yeah,
Yeah.
it was yeah. Dude,
Nice guy though, really
Yeah.
nice guy. Closing thoughts. if you think it cannot happen in your area, you're wrong. You know, you have to be prepared. You have to train. You know, at a minimum, maybe review the class from the state, review the concepts, RTF, train at your department, get with your police department, and know how to utilize your equipment, right? So I know Dr. Dayer mentioned it, like the tourniquet. So many times people improperly place the tourniquets too loose.
Simple things.
They just think that windlass they're going to turn is going to make up all the slack, and it's not. So tourniquet high and tight, as tight as you can absolutely get it from the Velcro aspect of it, and then tighten the windlass. That's mine.
How about you?
No, I think, I mean, we're all here talking about this because it is our new reality.
There's a need,
yeah. This is our reality. This is a need, and you have to prepare for that need. I mean, whatever your training is going to be, it's going to be different for everybody, but do something.
All right, you've been itching to do it. Push the button, take us out.
I agree.
Is that
This
the right
has
one?
been Tactical Medicine.
Got some Stranger Things.
Fantastic.